Hello. I hope you need to move around a little bit to wake up. It's hard in the afternoon. I'm Betsy Gornet. I'm in a position that didn't exist a year ago. I'm the Advanced Illness Management Executive. Sutter is a health system in Northern California that has 24 hospitals, some affiliation with 6,000 physicians, and has a home care-based affiliate that serves all the regions in Northern California as under one umbrella, with home health, hospice, home infusion therapy, home medical equipment, respiratory therapy, and private services. When I say that, it sounds like a fully integrated system. There's no such thing as a fully integrated system, I've discovered. So we are working towards common information systems, and we have our own 5 episodes of our versions of Epic within the system. That's just on the doctor side. On the hospital side, there's 24 different versions, it seems like. And then our home care agency uses a totally different information system. So you'll hear me comment on that in a second. So we embarked on this advanced illness management program in really in 2 parallel tracks initially. We were blind to each other's paths. In Sutter Care at Home, the home care-based agency, started a home health-based palliative care program some years ago, and I think actually was initially funded in the early 2000s by the Robert Wood Johnson Foundation. That was only exclusive for patients who met the Medicare eligibility for home health, and once they were discharged from home health, essentially there was no other additional services. And what that team started noticing, obviously, was those patients went back to the ED, were hospitalized, came back to home health, and the cycle repeated itself. So as an organization, we started saying, how do we fill in the gap between home health and hospice, between the physician offices and the EDs and home, and how do we begin to create a different model of care? Parallel to that, the interesting thing was the Sutter Medical Network, which is our umbrella physician organization, was also doing a strategic planning session around expanded care management for persons at the end of life. And we merged design teams and developed a new AIM 2.0 version, so the second version of Advanced Illness Management, which is really a care management model layered with palliative care services and care coordination that occurs over time, regardless of setting and place of the patient. And I'm going to describe 5 areas very briefly, about 5 descriptors about the patient population, 5 principles of the program, 5 pillars of the program in terms of the care pillars, 5 drivers of outcomes, and then 5 challenges, all in another couple minutes. So you've heard today, there's lots of different populations of palliative care patients, right? These are patients we describe as advanced illness patients with 2 or more chronic illnesses. One or more of them are advancing towards end stage. They take 18 to 30 medications a day, usually multiple times a day. They are seeing 9 or more physicians. They are experiencing clinical functional nutritional decline, which is unstable symptom management, which is creating the pattern back to the ED and back to the hospital. They have a high symptom burden, and their physicians definitely would not be surprised if they died within the next 12 to 18 months. The 5 principles of our model, this is really kind of the underlayment that drove the design features, which was really, we went to the literature and looked at all the demonstration projects that have occurred and all the different care management models out there, and what were the pearls from each of those experiences that we could build a new model in. One was the model had to be centered in the person's personal goals, not clinical goals of care, but personal goals. So really getting at what does the person think about, hope for, wish for, doing, experiencing, having in their lives today, and how might that change as they're informed about their disease prognosis and as different illness episodes happen, how does that change? And so we wanted to design a program to stay absolutely connected to that as much as possible. We wanted to marry the relationship between the patient and their family and the leading physician. Now, if you have 9 or more physicians, sometimes it's hard to tell who's that leader, who's that primary navigator. So part of that first step is helping the patient identify who that is for that patient. The third is a dual model of care. So they're receiving treatment, they're getting a layer of palliative care to help support their symptom management. And then evidence-based clinical care and care management skills or interventions. And then simplify and drive communication consistently, ongoing, timed-based, incident-driven, non-incident-driven, to all the providers of care that need to know it so that all the information's up to date just in time when the physician needs to have it. So 5 pillars of care. The first one is advanced care planning. These 5 pillars of care are what we do with every single intervention. And every single AIM team member does these interventions no matter where the patient is. We have an AIM team members in the hospital, embedded in doctor's offices, and in the home, and on the phone in telesupport visits. So they're talking about advanced care planning. How are their personal goals changing? What experiences are they having that make their goals or their objectives change for today, next month, and going forward? What are the self-management support tools they need to manage their red flag symptoms, those symptoms that cause them to go up to be distressed or have poor quality of life or end up in the ED or the hospital? Medication management. Just imagine the number of medications, the number of physicians, and getting discharged saying, oh, I've reconciled the medications. To what? You know, those medications change all the time. So med management. Follow up with their physicians on an ongoing basis, not just post-discharge, but for the next year. And a use of a personal health record and other engagement tools that help create self-management support. These are health literacy best tested tools and instruments that we're getting a lot of traction on. 5 drivers of outcome. I could mention several, but the 5 that I would mention here is our AIM team members have a heightened awareness and skill in assessing for health literacy, patient engagement, and self-management support. We've changed the way we teach patients dramatically. Consistency across all settings. Having someone skilled in this available where the patient is has been critical. We're doing this in sickness and in health so that it's not episodic. It's not based on whether a person's actually ill. We're also connected to them when they're feeling well. And frequent communication with the physicians in a predictable way. We use an SBAR format. We document those 5 pillars in SBAR format verbally and in writing, and the physicians can see it and glimpse at it really quickly and know kind of a status update whenever they want it. Our challenges have been, this has been huge. So we are now serving 1,300 or more patients a day. We did 30,000 visits last year, 6,000 telesupport visits. We are on our way to serving 10,800 patients under a Center for Medicare Innovations grant. Our goal is to demonstrate the model can be scaled and replicated and save Medicare $29 million. And at the moment, I'm pretty confident we're going to be able to make those targets. So our challenges have been training and retaining staff and clinicians who can do the model. The shifting between task-driven to a continuum of care is harder than you think. We kind of think one and done, and that's really not the case. The IS systems, the information systems is really hard. The team approach to care, hospice has been doing great team approach to care. That interdisciplinary team model has been great. Not everybody is familiar with it and knows how to do a shared model of decision making with the patient and family as a group. And then there are aspects of trying to train clinicians in all settings to do the patient engagement piece the same way so that they get consistency. So the same tools and the same vocabulary and the same assessments for the patients done in the doctor's office, done in the ED, done in the hospital, done at home, so there's consistency. Getting that in place has been a challenge too. So that's what I'll say.